Hello, everyone. I'm welcoming you all to our webinar, NOMO FOMO 2025. In case you missed it, recent changes in guidelines, new publications, and updates from recent conferences. My name is Constance Benson. I'm a professor of medicine at the University of California, San Diego, and I will be moderating this session today and welcome you to today's webinar. Our speaker for today is Dr. Roger Bedimo. He is a professor of medicine from the University of Texas Southwestern Medical Center and is chief of infectious diseases at the VA North Texas there, and the interim director of the Office of Global Health at UT Southwestern Medical Center. And his research interests include the analysis of rates and mechanisms of chronic complications of HIV disease and antiretroviral therapy, as well as the contribution of HCV co-infection on HIV-associated morbidity. Dr. Bedimo is also a clinical research site leader for the AIDS Clinical Trials Group and a member of the DHHS HIV Treatment Guidelines panel. Next. So I'm going to be doing a little bit of housekeeping for you all before we jump right into our webinar. And let me just start with our financial relationships with ineligible companies within the last 2 years. The first slide here summarizes those financial relationships for those who are the members of our webinar board of directors. And on the next slide are financial relationships with ineligible companies for myself and our presenter, Dr. Bedimo. So please review those at your leisure. I'll provide a little bit of CME information. The IAS-USA is accredited by the ACCME to provide continuing medical education for physicians and designates this live activity for a maximum of 1.25 AMA PRA Category 1 credits. And also, the activity has been approved for up to the same number of credits for ABIM mock points, nursing contact hours, hours of pharmacotherapy credit, and pharmacy contact hours. I just want to acknowledge our grant support for this activity, and our contributors are Gilead Sciences, Merck & Company, and ViiV Health, as well as all of you as registrants. I just want to give you a little background in navigating the activity. There will be poll questions interspersed throughout the talk before and after. A separate window will show the poll questions. You can choose your response for the polls, and we will display those responses after the poll closes. If you want to submit a question during today's webinar, please submit your questions using the Q&A button. We apologize in advance if we're not able to address all of your questions in the time allotted, but we'll do our best to do so. There is a chat open to start discussions with other attendees, but we really would love you to submit questions through the Q&A button, not through the chat. The chat will primarily be used by myself and the presenter as we go through today's discussion. So I'm going to turn over the program now to Dr. Bedimo. You've already heard my introduction to him. He's going to share his slides with you, and we'll begin with the session with Dr. Bedimo, and I'll come back to you as the moderator as we move along.
Thank you so much, Dr. Benson, and thank you all for participating in this educational activity. And I would also like to thank you very much for remaining steadfast in your focus on the people that we want to care for, people with HIV or at risk for HIV, despite the headwinds we're facing. So this activity also comes at a good time because the IAS-USA has just issued guidelines for management and prevention for HIV at the end of 2024. So I will be referencing those guidelines in this talk. Let's see if I can progress, if I can advance. All right. So what we would like to cover is that at the end of this activity, we would like to have the attendees be able to describe notable changes in the guidelines that are designed for optimize the care for people with HIV and actually at risk for HIV, and then summarize recent data on prevention and management that includes HIV and co-infections, syphilis, chlamydia, mpox, and COVID. We also would like to describe the recent data on the management of non-AIDS related complications of HIV, including cardiometabolic risk and the weight gain. Then at the end of it all, we want to package the information we shared today by incorporating it into evidence-based recommendation into the management of people with HIV and comorbidities. So here's to begin a pre-test question. Now, a 68-year-old man who has sex with men was diagnosed with HIV 20 years ago. He is virologically suppressed on stable antiretroviral therapy. His CD4 count is 640. Comorbidities include type 2 diabetes, hypertension, atherosclerotic cardiovascular disease, and acute myocardial infarction 3 years ago. He also has prostate cancer, not unusual in our aging population with HIV. He leads a very sedentary lifestyle and has noticed increasing weakness and falls. Which of the following statements is correct? A, the recent forecasting indicates that by 2030, a quarter of people with HIV will be living with physical comorbidities. B, recent data showed that epigenetic aging significantly accelerates in people with HIV despite virologic suppression and immune recovery. C, epigenetic advancement, age advancement is associated with greater mortality after adjusting for chronological age. And D, survival gap between this patient and the general population, his age, is estimated to be about 20 years or more. Please go ahead and vote. All right, so the majority of people say that epigenetic age advancement is associated with greater mortality after adjusting for chronological age. Thank you for the answer. Let's go to the next question. A 45-year-old Black man who has sex with men has been on HIV pre-exposure prophylaxis with TDF, tenofovir desoxyfumarate, and emtricitabine, FTC, for the past 2 years. He has heard about new options for prevention with injectable antiretrovirals and also asked about options for preventing sexually transmitted infections. Which of the following statements is correct? In the so-called Purpose 1 and Purpose 2 trials, which are defined below, lenacapavir every 6 months was found to be just as efficacious as TDF-FTC for the prevention of HIV. B, HIV pre-exposure prophylaxis recipients who take doxycycline pre-exposure prophylaxis has significantly reduced risk of chlamydia and gonorrhea, but not syphilis. C, recommendations for rapid HIV treatment start should be followed for people who acquire HIV while on PrEP, similar to people who are not on PrEP, regardless of PrEP modality. And D, antiretroviral therapy with darunavir is preferable for people who acquire HIV while on cabotegravir PrEP if integrase transferase inhibitor genotyping is not available before starting therapy. Please go ahead and vote. All right, so the slight majority, 37%, said that in Purpose 1 and 2 trials, lenacapavir every 6 months was found to be as efficacious as TDF-FTC for HIV prevention. Okay, so with these answers in mind, this is what we want to cover. are we on track for ending the HIV epidemic? And we know there are headwinds now, so this answer may be even more challenging to provide. Two, management of treatment naive and treatment experienced people with HIV. We'll talk a lot about two drug trials, dolutegravir 3TC, but also cabotegravir Ripivirine, and then oral bictegravir and lenacapavir newer in ATIS-3-1 trial, and then prevention and management of opportunistic infections, and then third, non-AIDS complications of HIV disease. We will talk about cardiovascular disease, especially in the context of weight gain, as well as fracture risk management, prevention and management in people with HIV. We'll finish with a couple of words on COVID-19 and Mpox. So first, progress towards the end of HIV epidemic. Are we on track? And what about PrEP and new modalities? So this is what has been our focus for the past few years: reduce the prevalence of HIV in persons capable of transmitting it, achieving on the, at least less than 1 per 100,000 HIV by WHO epidemic definition, epidemic control, also reducing the death. And so 75% reduction in HIV in 5 years, this was 5 years ago, and then 90% reduction in 10 years, which is now in 5 years. So how do we plan to achieve that? By diagnosing as many people as we can, treating those we diagnose, preventing those at risk, and responding quickly when fire breaks out. So we're not on track. This is a very nice paper published 6 months ago that shows you that if you look at the background risk of HIV in all these prevention trials dating from 2013 and comparing them with the recent trials in 2023 in different geographic settings from North America to Africa, you will see that there hasn't been a whole lot of progress in reducing the incidence of HIV infection. However, we could. One of the 4 pillars for prevention is pre-exposure prophylaxis. And we have seen a number of trials on pre-exposure prophylaxis, from PrEP 1.0 with TDF to PrEP 1.1 with TAF to PrEP 2.0 with cabotegravir ripivirine, and then finally PrEP 3.0 that we're going to discuss now with lenacapavir coming soon to a pharmacy near you. If you use PrEP, you prevent HIV infections. Now, this sounds like an oxymoron, but it has to be stated and it had to be studied. And this is a nice dose response curve that looked at the quarter of PrEP use in the population with the reduction in HIV transmission. So this is something that is available, is at our disposal. We could use more of it. Now, speaking of PrEP 3.0, this is the newest kid on the block, lenacapavir. And in this particular study, this is a series of a couple of studies. This is the first one, also called Purpose 1, where people were screened. And this one is for cisgender women not receiving PrEP and without HIV in the past 3 months. The innovative part of this is that they tested them. If they were negative, then they were randomized into those 3 arms, lenacapavir every 6 months, oral FTC TAF, and the active control being oral FTDF. Those who were found to be infected, there was a look back to assess when they were infected. And from that data, they derived a background HIV incidence in the population. So now we could compare these 4 groups, the 4 treatment groups, lenacapavir, TAF, FTDF, and the background without intervention in the look back. And these are the results. They're not, you don't need to be a statistician to see that there was 0 infection in the lenacapavir group. The first time this data was presented in Munich last July, it led to a standing ovation. No infection on the 2,134 were receiving lenacapavir, but the background here was 2.41 per 100 person years. And you can also note as a subtext that FTAF did not perform very well. If you look at the curves on the on the right, you see that there was no significant decrease in infections in those who receive FTAF compared to the background. So HIV incidence with lenacapavir were therefore significantly lower than background HIV incidence, and also significantly lower than receiving FTDF and FTAF for that measure. The second study, also called PURPOSE, but this time PURPOSE 2, is on transgender women and men with sex with men, and then who were not receiving PrEP, similar to the previous one. And then similar to the previous study, there was an HIV look back to identify the background incidence of HIV infection. Over that background, they will compare this time the two arms. There were no three arms, two arms, lenacapavir or FTDF. Similar results almost, in that HIV incidence with lenacapavir was significantly lower than background and significantly lower than FTDF. Here in the lenacapavir, there were two infections rather than the zero that we found in the previous study. So there is likely to be approval of this PrEP modality that a lot of people are excited about, and then we will be responding at IAS-USA with guidelines on how to best use it. So for now, this is what we have. If you do acquire HIV while receiving pre-exposure prophylaxis with FTDF, we should have a blood sample for genotyping drawn prior to initiating therapy with 3-drug therapy, and preferably use dolutegravir, bictegravir, i.e. INSTI based regimen. Those who acquire HIV after exposure to cabotegravir pre-exposure prophylaxis should also have blood draw for INSTI genotyping drawn prior to beginning. But in this group, very important, who received a PrEP with cabotegravir, it is best to not give them ART with an integrase inhibitor if genotype is not available. So if therapy was desired prior to genotype results being available to check for INSTI resistance, it is preferable to use ritonavir or cobicistat boosted darunavir therapy in these people. So now let's look at the progress in management of treatment-naive and treatment-experienced patients. We have dolutegravir 3TC, we have cabotegravir, rilpivirine, and a little look at lenacapavir based regimen. Now, as a preface, you will notice that there is no new regimens being explored out there that contains more than 2 drugs. So the dual therapy era is upon us, and that is not likely to change anytime soon. So prior to that, these are our recommendations. The following are recommended in alphabetic order or by anchor drugs. For people with HIV, bictegravir, FTC TAF, dolutegravir plus TDF for TAF, FTC or 3TC, and dolutegravir 3TC. The caveat here is that for that third option, there are limited data on using dolutegravir 3TC for initial therapy in people who have a low CD4 count, less than 200. And as you may recall, in the registration trials for that regimen, there was also a cap on a viral load of 500, even if 500,000, even if some people did exceed that. So a gap had remained in the field. Is it an option that is equally efficacious for people with low CD4 count or very high viral load? And this study is beginning to address that gap. And this is the so-called Dolce study. The primary endpoint was a proportion of subjects with a viral load of fewer than 50 copies at week 48. And in this study, people were selected if they had a CD4 count of less than 200 and a viral load of more than 1,000. You can see here that there were almost 40+ % of these people actually had a CD4 count of less than 100, as you see in the table on the right. You can also see in the table on the right that a whole third of the participants had a viral load of either over 500,000 or over 1 million. So these were people that stress tested that strategy of dual therapy with dolutegravir 3TC, and it passed the test because the virologic efficacy was similar for those who had dual therapy versus triple therapy, regardless of the viral load target or viral load pre-treatment viral load, so or pre-treatment CD4 count. So it's now important to follow up on this to see if we should remove that caveat that I just presented to you earlier in our latest guidelines. Then in terms of dual therapy again with injectable cabotegravir rilpivirine this time, there was a gap as well. There's an unmet need because the proof that patients had to give us for us to be comfortable giving this regimen according to the FDA approval is that they were virologically suppressed. Now, the problem is that the people who stand to benefit the most are people who are not virologically suppressed, who are struggling with adherence and suppression. So this was a very important trial because it selected just those people who had persistent HIV viremia over 200 or lost to follow-up or were not following up in clinic as indicated. Now, there were several steps. The first step was incentives. And the step 2, which is what we're going to focus on, the participants who achieve HIV RNA less than 200 were then randomized to receive monthly long-acting injectable or standard of care. And the primary composite endpoint was earliest occurrence of virologic failure or treatment discontinuation with these key secondary endpoint: treatment-related virologic failure and treatment discontinuation. And you can see here that this study was stopped at the DSMB early because of superior efficacy of long-acting cabotegravir rilpivirine in those 2 key secondary endpoints in the yellow highlight on the right. So there were fewer instances of virologic failure. There were fewer instances of treatment-related failure. So now this is how the IAS-USA, even prior to this, I must say, had already planned to respond that it's okay to switch therapy in people with blips, low-level viremia, or virologic failure, provided they were unable to take oral ART and they had advanced disease, so they were kind of circling the drain. And cabotegravir LA plus rilpivirine LA in conjunction with intensive case management. So it's not something to give them and let them go their merry way. They need intensive case management and adherence support that could be provided. And then, so this option should be considered if those could be provided. And we see here in the 3 bullet points, unable to take oral ART consistently despite your best effort, high risk of disease progression, evidenced by low CD4 count or history of AIDS-defining conditions, and a virus is susceptible, of course, to cabotegravir rilpivirine. So this is something that we should be pushing more of because, again, those were uncovered by what we had thus far. Now, PrEP 3.0 coming soon is bictegravir and lenacapavir. The Artistry-1 trial looked at adults with HIV RNA of fewer than 50 copies on complex antiretroviral therapies, 41% taking ART twice a day or more, 43% taking 2 pills, and 19% taking 3 pills, and then 72% being on PI. So this is a test is a trial of simplification with lenacapavir, bictegravir oral, and from those complex regimens. And as you can see on the right, that lenacapavir, bictegravir, either at the lenacapavir dose of 25 milligrams or 50 milligrams was non-inferior to keeping those complex ART. So this is a comforting finding published a couple of months ago in Clinical Infectious Diseases. Now let's move on to prevention and management of opportunistic infections. So doxycycline could be okay the morning after, and actually the 2 following mornings. And then we can see in the population studies that I'll show you 2 of them in San Francisco, Northern California, and San Francisco, that it actually does work. So this is what the trial predicted, or the trial showed. It's always good to see if real-world experience mirrors what was found on trials. And it looks like real-world experience actually exceeded, in some instances, what was shown in trials. And this is doxypep, and there was another one, doxyvac, that I will show you later. In doxypep, these 500 or so people who either with HIV or on PrEP were randomized to receive doxycycline 200 milligrams within 72 hours of an exposure, a condom-less sex. And then the primary efficacy endpoint here was incidence of 1 or more bacterial sexually transmitted infections per quarter follow-up. And the 3 STIs followed were GC, chlamydia, and early syphilis. And you can see here that the study was very positive, cut the rate of STIs to 1/3. And then if you look at secondary analysis by STI, you can see that the biggest drop was for any chlamydia or any syphilis. And then the second study called doxyvac looked at 2 different things, not doxycycline as well as vaccination. And then I will focus here on the conclusion on the doxycycline part of this study. Among MSMs on PrEP, doxypep significantly reduced the incidence of chlamydia and syphilis, and to a lesser extent, GC. And so, contrary to what preliminary data had shown, the Fauci-Menvy vaccine was no longer found to be significantly protective in final analysis. So this is the real world, Kaiser Permanente of Northern California, showing that among doxypep recipients, quarterly chlamydia positivity decreased by a whopping 80% after starting doxypep. You can see the curves on the left prior to intervention, and on the right post-intervention. But if you look at GC on the right, you see that the quarterly rectal, urethral, and gonorrhea positivity decreased, but mildly, while pharyngeal GC just did not decrease significantly. So that these studies are mirroring what was shown in doxypep and doxyvac studies. So greater decline in chlamydia and syphilis, so efficacy on GC. And then you can see here that for the syphilis thing, quarterly syphilis positivity also decreased by an impressive 80%, while positivity for STIs remained stable for those who were not receiving doxypep. So, second study, this time in San Francisco, monthly cases of chlamydia, gonorrhea, and early syphilis in San Francisco prior to and after initiation of doxypep. Again, it doesn't take much statistics. You can see the curve on the right, a steady incidence of these cases, and then a break that was calculated to be almost 50% decrease after initiating doxypep. And again, the decrease was significant for chlamydia and early syphilis, almost 50%, just about 50% each. So this is what IAS-USA recommends. doxycycline 200 milligrams in the form of doxypep within 72 hours of condomless sex for cisgender MSM and transgender women, regardless of HIV status. Because remember, doxypep had a PrEP arm and an HIV arm, so both are equally efficacious. So, and it's important to know that pharmacokinetic modeling suggests doxypep will also be effective for vaginal exposure and recommended on a case-by-case basis. So the recommendation is less strong because you don't have primary data. Also important to note that this is not PrEP. So it's not taking doxycycline every single day. This is post-exposure. So it's recommended for providers to provide a minimum allotment of drugs, so for 30 doses and at a time, so that to cover any incidental exposures. So now thanks to this progress, all the progress in HIV treatment, we have improved survival. And we will now examine just how improved and what comes with the improved survival. So here is prior to 2015. You can see in this progress, in these curves here, that compared to the general population in orange on the top, the survival of people with HIV from 1996 to 99, there was a significant gap, and that gap has narrowed every 5 years that this study examined, which is the good news. The bad news is that there was a gap that persisted nonetheless. But even better news is that when this was followed up since 2015, there was a continued improvement in the survival of people with HIV. If you look at the dotted line on top, for men on the right and for women on the left, you'll see that the survival gap between people with HIV and the general population is continuing to narrow. And it's narrowing even more for people who initiated antiretroviral therapy after 2015. Those are the solid lines. And it's narrowing even more for people who did not acquire the infection via IV drug use, because people with substance use disorder, and those are the the red lines, their survival is still significantly lower than that of the others. So that's the good news. The bad news is that this increased survival comes with an accumulation of comorbidities. Now, it's important to begin to understand just why people with HIV have so many age-related comorbidities. And enters this so-called epigenetic age advancement. Let's think of epigenetic modifications as things that are not written in your genes, but that modifies the product of your genes, the messenger RNA, after they've been transcribed. So all these so-called DNA methylation patterns, you can see here the called DNA. So this is not something in the genes, but something that is added or to the gene, or so-called epigenetic or around the gene modifications. These modifications are sort of like a clock that is somewhat better than the biologic clock, because it tells you what exactly it's even better than the chronological age, because it tells you what the biologic aging of the person is. Now, how does that work for people with HIV? It's been a very long debate about whether people with HIV actually have quote unquote accelerated aging. And I like to joke that it's not like people with HIV shift from human years to dog years when one of the years is like 7 of people without HIV. So is it true that epigenetic age advancement can be identified to be occurring at a higher rate in people with HIV than others? This study, albeit if a relatively short follow-up of 4 years, answered that epigenetic aging did not accelerate in a cohort of people with HIV with virologic suppression compared to age-mate peers. Now, that, be that as it may, if you were to observe increased DNA methylation as a marker for epigenetic age advancement. That is a good marker for badness to happen. More instances of cognitive changes and more instances of mortality in this particular analysis. So it is a good marker to have, and because it may lead us to understand why people with HIV has such a high risk of a number of complications. Now, I'll take us back 10 years when this question started. Is there evidence of accelerated aging in people with HIV? As a shameless advertisement, this was a VA aging cohort study that looked at, like many studies at the time, but the VA having a distinct advantage that it's at the cutting edge of the aging of HIV because the VA HIV population is so much older than the rest. Looking at AMI in this particular graph, it occurred at exactly the same median age or mean age in people with HIV and people without HIV, even if the rate of AMIs were a lot higher, 81% higher. So people with HIV appear, according to this study, to have a significantly increased incidence of age-related complications, but the median age when these complications happen doesn't seem to be earlier than people without HIV. This very new study in South Africa, in Southern Africa, in Eswatini, may be shedding the light in this, because if you follow me, this is people older than 50 with HIV in Eswatini. And what they looked at, comparing epigenetic age advancement markers in people who acquired HIV while already old versus who aged with the disease. It looked like HIV diagnosis at an older age was associated with a higher epigenetic aging markers. Conversely, those living with HIV for a long time since HIV diagnosis displayed lower epigenetic aging. How do I put it all together? As it might sound confusing. How do I put it all together? I think that when you acquire HIV, there is a sharp drop in your survival. That's an increase in aging markers, epigenetic age advancement. But from that drop, the curves are parallel, so you don't age faster than others after that initial drop. That is probably the picture that is emerging. But as you age, therefore, you are accumulating a number of comorbidities. And this is the forecast to 2030, which is in the mere 5 years. Almost half of people with HIV, according to this projection, will be living with 2 physical comorbidities or more. 2/3 will be living with at least 1 mental comorbidity or more. Now, this makes perfect sense, because if you look at the mortality of people with HIV today on stable antiretroviral therapy, it's driven by cardiovascular diseases, malignancies, suicide. So the low-hanging fruit is antiretroviral therapy, and that low-hanging fruit has been picked by shorter people. We need to look at how we impact people's lives after they've already been on therapy by preventing or mitigating the development of these age-related comorbidities. And these are numerous. We have cardiovascular disease, especially in the setting of increasing age, but we also have increased fracture risk that we need to manage in these people with HIV. We all probably know this story already for the past 6 or 8 years, that people with HIV on the newer antiretroviral agents, including integrase inhibitors and tenofovir, both in red in the left and on the right, appear to be associated with a greater weight gain. Now, the one thing I want to precise is I prefer to copy verbatim an excerpt from this paper, because there's a lot of misconception about weight gain in people with HIV. The majority of people who receive antiretroviral therapy do not gain weight compared to not receiving it. I repeat, the majority did not. And this paper that a lot of people quote said that through week 96, 48.6%, 36.6%, and 17.3% participants had at least 3%, 5%, or 10% increase in weight, respectively. Weight gain was not observed in all participants, and 30% lost weight. So it's important to put things in perspective when you are counseling people who go on the antiretroviral therapy. The other caveat I want to put in this paper is that we all know that you only receive antiretroviral therapy as a combination, not a single drug. So to assess what a single drug is doing, you need to add two more things. What other drugs were given the regimen? Number one. What are the changes in HIV parameters in terms of viremia, CD4 change, and the like? Number three, what is the background risk that we have to face in that particular person? So this is what we try to do in a study here in Dallas, because if you look on the left, you see that every time that you see changes at the bottom of the so-called anchor drug, moving from NNRTIs to PIs to integrase inhibitors, there are also changes in the backbones, TDF, then abacavir in green, then TAF. So you cannot analyze them in isolation. You have to combine them. And so when we did that and we added HIV characteristics, backgrounds, baseline CD4 count, baseline viral load, and changes in CD4 count and viral load, we found that antiretroviral drug choice accounted for less than 10% of the magnitude of weight change. Other things accounted for more HIV parameters. So keep that in mind as you navigate this nebulous weight change issue with HIV. Should it occur, is there something that you can or should do about it? The answer is also nuanced. In this particular study just published 3 months ago, switching people to darunavir cobicistat FTC TAF in the context of weight gain did not result in significant change in the trajectory of weight gain. So that is important. The other study from South Africa published over a year ago suggested that in that particular context, the one thing that was shown to show some reversibility of weight change is switching people who are on dolutegravir FTC TAF to dolutegravir 3TC TDF. Now, the majority of studies so far do not suggest that there is a meaningful change in weight should you switch antiretroviral therapy. Now, what else can you do? Now, we know that the talk of town today is the GLP-1 receptor agonist. Semaglutide is one of them. We know that it does work, it does decrease weight, and even better, it does decrease weight-related complications such as cardiovascular disease and others. The caveat and the cautionary tale is that it also does decrease lean mass. As our population ages and the frailty is a bigger issue on them, we need to keep that in mind because we might do more harm in some of these older people with HIV. Now, with the weight, we know that it's difficult to analyze that in a vacuum, but we know that people with HIV have an increased risk of cardiovascular disease. The problem is that we have been very bad at predicting that because the equations that we use, the formulas, the predictors, Framingham risk score, the pool cohort equation on the left and on the right, respectively, and even the newer one, the prevent score, which hasn't been analyzed in people with HIV yet, they do under-predict HIV-related cardiovascular disease. So that's why you see that the observed cardiovascular disease in people with HIV is much higher than were predicted by these equations. The reprieve study, which is a gift that keeps giving, has actually nuanced that quite a bit because the predictive value of these equations that you can calculate in your clinic is different depending on the person in front of you. You can see here that in high-income countries, that is indeed true. That there is an underestimation. That's why the dot is on the upside. That underestimation was not seen in low-income countries where a reprieve study was done. Now, if you look at the race, you see that the underestimation was much more pronounced in Black or African Americans in high-income countries. So if you see a Black woman in front of you and you do the pool cohort equation, you cannot trust the results. You probably get a little closer in if that person was white. And and again, by sex, you see that there is a significant underprediction if you're a female than if you're a male. So the picture gets even muddier. So let's just say that pool cohort equation was moderately effective in predicting cardiovascular death, MI, or stroke, which were the combined endpoint in the reprieve study, but underpredicted in females, in Blacks, in high-income countries. So we still think that we should take heed of the findings of the reprieve study. We showed that statins were significantly effective in reducing major adverse cardiovascular events that were found there. And so it's, even if pitavastatin is the statin that they use, we think that the findings can be translated to other statins, and the reduction was mostly seen in people with ASCVD score of 5% or greater. So it's important to take heed of that. So despite with cardiovascular disease, another age-related complication that we've seen is fracture risk. I'll put this diagram here to remind us of what we talked about earlier. People come into HIV with a background risk, which could be genetic, environmental, behavioral, and then HIV may add to it because of the inflammation and immune activation. Antiretroviral treatment may mitigate that or may accentuate that. We always have to look at this triad. And when we look at HIV, even in people who do not have cardiovascular disease overtly at the time that is obstructive, we see that they have subclinical coronary atherosclerosis at the higher rates than their matched peers. That is the curves on the left. And on the right, they have a higher risk of cardiovascular disease, whether it's non-obstructive or obstructive, than predicted by any score. Here they call it, they use the score 2. So familiar story, if you have a person with HIV in front of you, even if they don't have overt ASCVD, they are at a higher risk of having subclinical ASCVD. Now, do the drugs add to it, as the triad that I presented earlier suggests? This has been an issue for the past almost 18 years, since 2007, when it was first shown that abacavir exposure was associated with increased ASCVD. Now, in the past 3 years, the debate has been over INSTI use. And the so-called RESPOND cohort has shown that abacavir exposure, INSTI exposure was associated with increased risk of ASCVD within the first 6 months. That was no longer seen later. Incredibly reminiscent of the findings of the DAD cohort in 2007 regarding abacavir. However, this was not corroborated by other studies, including the Swiss cohort. So the Swiss cohort did not see that change. And here is another, target emulation trial from the HIV causal and RTC that also did not see an increased incidence of ASCVD associated with INSTI use. However, the reprieve, which is a gift that keeps giving, has reanalyzed an abacavir association with ASCVD risk and have found that there is an increased risk of ASCVD with abacavir use, and this, I believe, will soon be published. So it's important now to consider that maybe what the DAD cohort started showing us in 2007, there is a meaning to that. There's a number of other studies not ready for prime time that are looking at association of ART and cardiovascular event in people with HIV. But what I would like to point to is that according to the RTC and the Swiss cohort, INSTIs were not found to be associated with an increased risk of ASCVD. And in this particular analysis, they were also not found to be associated with increased risk of diabetes. Now, we need to get further data, but this is comforting, as I showed you earlier, that most of our patients are on these regimens now. And finally, in Reprieve, this is still in press, but has looked at the factors affecting the risk of cardiovascular disease in this global study of 7,769 people. Very nice to see that it corroborated what we know, that cigarette smoking was bad for you, in case you haven't been convinced of that yet. A hazard ratio of 2.2. So is hypertension, so is low HDL, and so is remaining viremic, even at the lower level. So if your viremia is above the lower limit of quantification, you actually have a significantly high risk of major adverse cardiovascular events. Older age is bad. Yeah, sorry. But, and so it was a dose response. If you're older than 60, compared to 40 and 49, by the way, a Reprieve cutoff was 40, you had a very high incidence, and living in a high income country also did. So the one thing that did not, was not seen in Reprieve is that female sex was not associated with a lower incidence. And so it's important to see that in this population of exclusively people with HIV, the things that we're seeing in the general population from several years still apply. Now let's look at fracture risk. What we see on the left are DEXA images of two bones that have the same bone mineral density, almost the same. But as we move towards the right, we see that the bone on the top is uniformly thin in this macroarchitecture, while the bone at the bottom has big holes and dense areas. So the new algorithm called the trabecular bone score averages these pixel-to-pixel variations between porous parts and dense parts and calculates what they call trabecular bone score. It gives a higher value to this bone that is uniformly thin than in this bone that is chewed up in parts. You may intuit that the bone at the bottom is probably more fragile, and you will be right. So the low trabecular bone score has been shown to be associated with high fracture risk, even if you control for the BMD. So how does that apply to people with HIV? You can see that on the left, you have two populations, with or without HIV, with HIV in red, without HIV in blue. If you look at the lumbar bone BMD, similar. Femoral neck, similar. Total hip, slightly thinner in the people with HIV. But on the right, the trabecular bone score is a lot lower in people with HIV than without HIV. Mind you, this TBS score is calculated from the lumbar region where bone mineral density is the same. So we now think that this is a test that is, you know, that if you do live with HIV, we ask you to start getting bone mineral density at age 50. And then my contention is that we have no idea whether this is sufficient. So if you find that the person has a normal BMD, doesn't mean that the fracture risk is low? Probably not, according to the new data. More importantly, Cox regression analysis showed that reduced trabecular bone score was a significant predictor of vertebral fractures, whereas BMD was not. So I think we ought to get more sophisticated in evaluating the very real fracture risk in people with HIV by utilizing these modalities rather than relying on bone mineral density. So let's close with some thoughts about COVID and Mpox. So good news on COVID, because people with HIV could use some good news, is that the sequelae symptoms or long COVID or post-acute sequelae appear to be less prevalent in people with HIV than people without HIV in this Chinese study published 2 months ago. Even better news is that with the subsequent waves of COVID, it appears, according to this analysis, that the incidence of post-acute sequelae is lower, or recovery is faster with Omicron than it was with the parent strain. So maybe we're getting more used to COVID and recovering faster from its impact on our immune system that leads probably to this post-acute sequelae. A better news, again, is that Mpox vaccines do work. This is a vaccine effectiveness study in England that showed that either 1 or 2 doses were associated with about 80% protection. This is good. The bad news is that if you go to places where Mpox is more prevalent, like in the Congo, vaccine availability is less than adequate. So I hope that we ran through a number of things that looked at treatment and prevention of HIV as well as Mpox and COVID. So now let's, to conclude, revisit these questions. Our question number 1, where 70% of people already answered it correctly the first time around, is this person who is 68 years old and have been living with HIV for 20 years, has a very respectable CD4 count of 640, a number of comorbidities, a sedentary lifestyle, and has noticed increased frailty, weakness, and fall. So which is correct? According to the forecast, a quarter of people like him will be living with physical comorbidities by 2030. B, recent data show that epidemic aging significantly accelerates in people with HIV despite virologic suppression. C, epigenetic age advancement is associated with greater mortality after adjusting for chronological age. Or D, the survival gap between people with HIV and general population is 20 years or more. Please go ahead and vote. Please call more than 70%, because that's what you did last time. All right, let's see the results. Results. Drum roll. Okay, 2% higher. Thank you. So again, the correct answer is C. Epigenetic age advancement is associated with greater risk of mortality and also some of greater risk of some comorbidities. However, it doesn't seem to accelerate faster in people with HIV. It just it's greater as soon as they acquire HIV. So, and that's the correct answer here. And then the second question in the so-called purpose 1 and 2 study, is lenacapavir every 6 months found to be as efficacious as TDF-FTC for HIV prevention? That's A. B, HIV pre-exposure prophylaxis in HIV pre-exposure prophylaxis recipients, is doxycycline post-exposure prophylaxis, PEP, significantly reduce chlamydia and gonorrhea but not syphilis? Or C, recommendations for rapid HIV treatment start should be followed the same as in people who are not on PrEP, regardless of PrEP modality, or D, antiretroviral therapy with darunavir is preferable for people who acquire HIV while on cabotegravir pre-exposure prophylaxis. Please go ahead and vote. Let's see the results. Okay, so let's, okay, great. I did not see the bar at the bottom. So 53% had the correct answer. And let's look at the answers. So purpose 1 and purpose 2 showed that lenacapavir was superior to TDF-FTC. That's answer A is false. HIV pre-exposure prophylaxis significantly reduces the incidence of chlamydia and early syphilis. The GC reduction is marginal. So the answer B is false. Answer C and D, it's important to note that if you're on pre-exposure prophylaxis with cabotegravir, you should not use integrase inhibitor, either bictegravir or dolutegravir, if you do not have genotyping available. Please use darunavir. So that answers C and D. So I want to thank you very much for your attention, and I think that I can stop sharing now and be open for questions and answers.
Well, that was a fantastic tour de force, Dr. Bedimo. There's a lot of new things happening in the world of HIV research, and you did a wonderful summary of a lot of different data from the last 6 to 9 months. So we very much appreciate that. I'm going to start off with some questions from the Q&A, and then I'll go to some questions that were submitted ahead of time. So I guess this first question goes back to your discussion about epigenetic aging, and I found that to be particularly fascinating. I feel like I'm epigenetically in the toilet right now, so I think most of us are aging rapidly. Can change in telomere length be used as a biomarker for epigenetic accelerated aging in people with HIV? Is there a relationship between that?
That's a great question. This is one particular test I will not submit myself to. I don't want to see I don't want to know the answer. So it is just a different clock. So the telomere shorten as you age, and I think the current environment is a telomere shortening event as well, but it's measuring something different. The epigenetic epigenetic modifications of DNA, mainly DNA methylation, is the things that wrap around the DNA while the telomere is the tail ends of the DNA. But they're just different measurements of biologic aging.
Great, thank you. Next question, should the cap of a viral load of 500,000 copies per ml for Dovato be removed now that we have the results of the Dolce study?
If you notice, it actually is not in the FDA authorization for it. So that's number one. So it's a caution from all of us guideline bodies. And we're getting, as more data emerges, both from real world and trials like Dolce, we're getting more comfortable removing that caution.
Okay. And then third question from the Q&A, should abacavir 3-TC dolutegravir be switched to a non-abacavir ART regimen in people with high cardiovascular disease risk?
Our contention at IAS-USA is that yes, unequivocally, and I think that the latest evidence has come from the reprieve study. And the other evidence is that there is, according to many studies, including Dolce that are presented, there is nothing lost by removing abacavir in a regimen of abacavir, dolutegravir, 3TC, and keeping the last two. In terms of intensity of virologic efficacy or otherwise. So I'm perfectly okay peeling off the abacavir.
Yes, I would concur with that. So here are some more questions. I'll start from some that were submitted and then go back to the Q&A as we accumulate questions there. This is more of a general comment or commentary or question. Based on all of the data you reviewed today, what would you recommend as the top 3 papers for your audience to read based on your presentation? What were your
Oh dear.
favorites or ones that had the most notable findings?
Well, let's go by the papers that are the most comprehensive. So that gives you a better picture of how to manage someone with HIV, and that's most concise. And shameless advertisement, I will cite IAS-USA guidelines as well as the DHHS guidelines, a little more excessive. The second one being the primary care guidelines. I think that what we see in our clinic today, the joke is that I went into infectious diseases because general medicine was too broad. I wanted to narrow it down a little bit. And then from infectious diseases, I went into HIV care because the whole infectious disease is too broad and I wanted to narrow it down a little bit. Now the joke is on me because practicing HIV now is general internal medicine, because what I do mostly in clinic is cardiovascular disease prevention and cancer stuff. So that's why the second paper I would say is my good friend Melanie Thompson's paper on primary care guidelines for people with HIV. And you can select a number of third papers.
Okay, nice dodge on that one. I know this is a burning question for all of us in HIV clinical medicine as we get bombarded with the data right and left. What is your thought on the ideal and optimal weight loss drug to be started in people with HIV with obesity? And if you have a recommendation, what dose and frequency would you use?
Well, yeah, so it is an issue that unfortunately is plaguing most of America. A third of us are overweight or obese, and if not more, and is growing. And we know that it's not just a cosmetic problem. It's associated with real healthcare consequences. So reducing weight is important, not just in a patient population, but the general population. And we know that managing antiretrovirals probably not the efficacious in that. So I know it's said a lot, but diet and exercise still do work by and large. And when it comes to medications for weight loss, just a recent, we know that the GLP-1 receptor agonists are very efficacious in reducing 13, 15, 20% of weight. I gave you the caveat of muscle mass, so you should combine that with exercise. But newer data, now was actually a paper published just a few days ago, suggests that if you do not have access to GLP-1 receptor agonists, and access is not given, don't forget other drugs, especially in people with insulin resistance. Metformin is still efficacious again, and then think about that, and that not everyone has access to GLP-1 receptor agonists or GIPs.
So that was a great response. Thank you. Back to the Q&A section, I'm going to combine two questions from the same person. Since you presented more of the data on lenacapavir in PrEP and lenacapavir in people who have advanced disease on complex regimens, what are the data supporting the use of lenacapavir for primary HIV treatment, initial treatment for people with HIV?
Well, yeah, good question. We'll go where the evidence lead us, and of course, it's going to continue to accumulate for newer drugs like lenacapavir. And you see that early on we had the Capella study and the name of the other one escapes me. That was for the heavily treatment experience. So there have been lenacapavir studies on heavily treatment experience on the one hand, and at the very other end of the spectrum on antiretroviral naive people. We think that as data continues to accumulate, we will get updated guidance.
Yeah, I think the primary phase 3 trials of lenacapavir for treatment of HIV in people who are not, late stage on multi-drug complex regimens, those data are continuing to accumulate, and that study's not quite finished yet. So I think we'll see more data presented this year on that study. So going back to earlier questions, I guess this goes back to other questions about lenacapavir, and given the recent results of Purpose 1 and Purpose 2 and what we know about cabotegravir and other regimens, what would be your preferred PrEP regimen? Are you going to switch over to using lenacapavir and replace those other regimens?
Really, it's important to look at what has been compared thus far, and with Purpose 1 and Purpose 2, they really overperformed the TDF and TAF, so it's important to keep that. Now, the problem or the challenge we're having is that this situation is calling for a completely different care modality pattern. So we no longer saying, here is one pack of 30 drugs and with 3 refills come back to get viral loads and SCR testing. This is a very different model, and I think we're very happy that this modality is not every 2 months, but every 6 months. And we need to figure out what's going to happen of adverse events that have been seen, including the nodules, and how tolerable they will be for people to see what the appetite would be for this very new modality.
Okay, so we need a little bit more information before making a final decision about preferred regimens. More questions from the Q&A. Are there any ongoing studies of 2-drug regimens in pregnancy that you're aware of?
I must plead ignorance on this one. I'm happy to check on that and get back to you. But one thing what we know now is that cabotegravir for PrEP is approved for people who are pregnant, and that's a very good thing that it does work. So in terms of treating cabotegravir and with either integrase or lenacapavir for people who are pregnant, we may need to come up with the studies and get back to you.
Okay, so we can follow up after the webinar with response to the rest of that question. one more time. I think we have time for one or two more questions. Considering all the conflicting data and other factors that you discussed, what do you advise your patients about weight gain once they start antiretroviral therapy? Are you making specific recommendations to them?
Yeah. What I tell my colleagues and trainees alike is that the first thing is to admit our ignorance. And in terms of the trajectories that the weight of a specific person in front of us will take, because as you saw in the data I showed you, there's a great variability in that. And so having the potential, telling the patients that there's a potential for weight gain, that all we know now is that you are a female, if you're Black, you're probably more likely to gain weight than others, but that's about all we know. We don't have predictors of weight gain, which we need to come up with some measurement of predictor adipokines or other things. So, and then after that, we tell them that, I would tell them that there are other things than simply the drugs that come into the equation for weight gain on our standard antiretroviral therapy, because the medications impact your immune system as well as inflammation and immune activation. So that those changes are correlated with weight change. CD4 can change, are correlated with weight change. So regardless of the antiretroviral. So we need to be a bit more sober in our analysis of what led to weight change or how much weight change will likely to occur.
Great. Well, thank you. There are a few questions left over that were submitted, and we'll make every attempt to address those on the website. I just want to thank you for a wonderful presentation and to the audience for great questions that really added to the discussion. The presentation slides and the on-demand recording will be available within 24 hours for those of you who'd like to access it after this presentation, and you can go to our website for further updates related to that. We'd love to hear from you with your evaluations and information on how to claim CME, complete your evaluations, and receive a certificate of participation will all be available by tomorrow. Your feedback is very important to us so we can continue to improve our content and our educational programs. And we encourage you to go to the website for any further information about things that are ongoing. While we're continuing to close, we'll have a few closing slides about upcoming events. The next is an update on COVID-19 with Dr. Andy Pavia and Dr. Sag. And podcast, our upcoming webinar on the Last Gift program, lessons learned from altruistic participants enrolled in HIV cure research at the end of life. That will take place on March 21st with Sarah Gianella Weibel presenting and Davy Smith moderating. And of course, big plug for CROI 2025, which will take place this year in San Francisco on March 9th to 12th. And we hope to see most of you there. If you are attending in person or virtually, it's going to be a fantastic program. And we will continue to hold that program despite any of the disruptions that may have occurred from our recent actions. Just putting a plug in too for the Scott M. Hammer annual update on HIV management in New York. That takes place in person on March 24th at the Skirball Center at NYU in New York with a great faculty and a lot of updates. And likewise, an annual update on HIV management being held in Atlanta, Georgia on April 2nd at the Loudermilk Conference Center in Atlanta. And then lastly, the latest update on urgent virus outbreaks, which will cover a vast majority of what's going on, or at least what we know about in the world about new outbreaks of Marburg, Ebola, H5N1, and Mpox around the globe. moderated by Carlos Del Rio and discussed by Peter Chin Hong and Yvonne Maldonado. And then a last plug, conference on bacteriophages, a new approach to treating multi-drug resistant antimicrobial infections. And we're starting a new effort to get information out to the field about biology, dynamics, and therapeutics with bacteriophage. And that will take place in Washington, D.C., October 12th to 14th. So thank you all for your participation and a great conference. We hope to see you again in a future webinar. And that's it for today's program.
Thank you so much, Dr. Benson, and thanks to the audience, and thanks to the IAS-USA. Looking forward to San Francisco.
Great. Bye, everyone.